Post cryoablation, medications to be continued. Are the patients on some antiarrhythmics or anticoagulants? You continue them for how long?
Regarding anticoagulation, I think already we've stressed multiple times. Anticoagulation depends on chart score. You don't worry about how long you are keeping the patient in sinus rhythm. If the patient has a documented atrial fibrillation, even if you ablated the patient, if the chart score demands anticoagulation, you have to continue with anticoagulation. Regarding antiarrhythmics, the patients who had a standalone atrial fibrillation, like a proximal atrial fibrillation, like we had around 12 cases so far in KMCH. I think around 11 of them were proximal atrial fibrillation. What I usually do is, for a month I continue them on antiarrhythmics with anticoagulation. At third month, I usually take a call on antiarrhythmics depending on patient's comorbidities and risk profile. If it's a proximal atrial fibrillation with a normal sized LA, I stop all antiarrhythmics. If the patient CHA2DS score is there for suitable for anticoagulation, just continue with the anticoagulation. If the patient is a 45-year-old male with a CHA2DS score of 0, I stop everything. The patient is not on any drugs at all after cryoablation, maybe at 3 months.
Lawrence, one quick question. How are you monitoring whether the patient has recurred to atrial fibrillation?
See, right now we don't do a internal loop recorder like what they do in US. One is symptom driven. If the patient complains of palpitation, because fortunately, because it's a costlier therapy, most of the patients were highly symptomatic. The patients whom we ablated so far are highly symptomatic, and for the last 1 year, they never had a clinical recurrence or symptomatic recurrence. Few patients, maybe 2 or 3, we did a 3 to 7 days monitoring, because these patients were highly symptomatic with daily AF burden crossing more than 30-40%. These patients never had a AF recurrence in the 7 days monitoring. So that's the longest monitoring we have done so far in a patient. 7 days is the maximum time for a continuous monitoring, but nobody had a clinical recurrence.
Okay, my second question is, from your talk, looks like a cryo for all AFs, irrespective. Which patient subsets which you will not give cryo as the first choice? You will hesitate, okay, we'll...
You are asking for cryo versus RF or...
No, I mean, cryo versus medical management, which you will not offer cryo as the first choice. Looks like you want to cryoablate every AF, which you are seeing. So, for any reasons or any contraindications really for cryo is my question.
See, like already Dr. M.B.B.S has shown you slides where we don't offer ablation for a group of patients whom the success rates are lesser. Maybe the dilated LA, the patients who have a structurally abnormal heart. Earlier they were little worried about HCM. Now people ablate HCM also. If you ask me when you advise cryo, maybe that if that's the question, you see a patient first with the atrial fibrillation, do you advise cryo? No. Most of the patients right now what we have is maybe a cost issue or a awareness issue. Most of them are highly symptomatic. These are the patients who are a proximal AF more than around, I think none of my patients had episodes less than around 6 to 7 in a year. So few of them have been cardioverted, and the significant quality of life impairment. So these are the patients who, most of the patients whom I done cryo have walked into my OPD for a cryoablation, to be fair. So because they understood that cryoablation is done in this center, so they have a problem, either a physician told go and get it done, or they themselves, there are around 50% of the patient, there are own referrals by themselves. They walked into my OPD saying, I have a problem, and we heard you have cryo, we want to get it done. So I think the time will come that more and more data are accumulating, the cryo may become a first line therapy. Right now, we definitely offer all the patients who are refractory drug to a cryoablation right now. I think the data is so good that the time will come, it may become a first line therapy.
The presence of heart failure or reduced ejection fraction, does it change the threshold for doing RF ablation?
It depends which causes what. If the patient has an atrial fibrillation, which is causing a heart failure, definitely it is going to improve. One of the indications for ablating patients with atrial fibrillation remains heart failure, because it could be a heart failure related to the arrhythmia. But if you know the patient who has an ejection fraction of 15-20% for a long time, presence with the atrial fibrillation, it is secondary to a LV dysfunction and raised end diastolic pressures. We know very well here you just go and ablate is not going to change anything. Here the management of heart failure will improve the atrial fibrillation. You improve the hemodynamics inside the heart. You prevent the LV end diastolic pressures to go up and get transmitted to the LA. This patient will do better. So if the AF is reason behind heart failure, definitely AF ablation will help. If there are no more questions, we'll move on to the next talk. Dr. Manindra, please. Thank you.